Hi, everybody. Thank you so much for joining me again for this to learn a bit more about the emergency department and emergency condition. So today we're going to be discussing injuries of the patella. So I'm carrying on with our series on emergency radiology. Having started at the C-spine and the face, we're now down to the knee, and hopefully soon we'll be going down to the lower limbs. And I mean, we are discussing the chest slowly but surely in the others, but this at least will give you some idea of some of the other problems that you may come across in your career. So this is one of the most common injuries of the patella that you will see, which is a patellar dislocation. Now, patellar dislocations are not something you're going to see every day, but they do occur quite frequently. They're normally associated with, those who are engaged in physical activity, particularly soccer. In our context, those who are involved in climbing also have a tendency to dislocate the patellas. And normally what happens is that you have one or two scenarios. The first one is a spontaneously relocating patella, and the other one is now a dislocated patella that cannot spontaneously reduce. So if you have a patella that is, sorry, I just want to get the pointer up here. So if you get a patella that is dislocated, it's actually quite easy to see on X-ray. I mean, you just have to look at the, the skyline view, which you can take, or let's just say an AP of the knee, and you can see that the patella is normally laterally displaced. It's very rare for it to go medially. It tends to go laterally, but it can displace medially on the rare occasions. And on an AP, you can see it quite easily, In the lateral, it's not that easy to see. You may sometimes see it a bit superiorly or a bit inferiorly, but the main thing that you notice is a lot of swelling. Now, the other thing that you get as well is spontaneously reduced patella, which is surprisingly common. Patients in their, because it's an extreme pain. If you've ever seen anybody dislocate the patella, especially if it's a new dislocation, it's extremely painful. And a lot of them will instinctively just push their patella back into place, or they'll try flexing their hips and moving their legs, and somehow they get it back in, but it doesn't decrease the amount of pain that they are in at that point, and they can still be experiencing quite severe pain, especially if there's ligament tears and things like that. But if you do get somebody who is who hasn't had a spontaneous reduction, then of course you just flex their hip ever so slightly and extend the leg under sedation, preferably under conscious sedation, such as ketamine or very strong analgesia, and that would help. And then you give a bit of gentle medial pressure to the patella, and it generally will slip back in. So you do get difficult reductions as well, and you sometimes have to hyperextend the leg in order to so in other words, you're going to be extending the leg. Let's see if we can get it drawn here. So in other words, your tibia and let me just get this here, sorry. So your tibia and fibula will then end up going in this direction eventually. All right. No, maybe not that much, maybe around there. But that just gives you a bit of an angle to work with, and then to get the patella in there. But that doesn't happen very often. And those who have had a spontaneous reduction will still require splinting, because they're at great risk of redislocation. And even after you've done a reduction, the patella is one of those I've noticed over the years that tends to pop out quite a bit. Once it's popped out, it tends to pop out again and again and again. Now, this is not to say that every single patient who has a patellar dislocation needs to go to theater and have it fixed. No. They often just require a bit of support, be it a back slab or a knee support or something like that, depending on what the orthopedic surgeon likes, and keeping it immobilized for a few weeks. And normally any laxity that's there in the tendons will resolve, and the patient will go back to their normal selves. in patients who have had recurrent dislocation, there normally is a congenital lengthening of the patellar tendon, and that's why it tends to slip out of place. And very often these patients need a type of fixation. I've never been privy to any of these procedures, so I don't know exactly how they do the fixation of the patella. But you know, the patella is extremely important because it actually provides you with the necessary leverage to move your tibia and your fibula. Without it, it would take a great deal of force for your quadriceps to actually be able to move it. There's a lovely video on the web. I'll try and look for it and maybe link it at the end of this, that shows you know, with the wooden sticks, how difficult it is to actually move, you know, a knee without a patella, and how easy it is with the patella as well. And you know, they also explain why babies don't have patellas, and that's why it's so difficult for them to walk as well initially, because they can't, they don't have that strength and things like that. So it's quite an amazing little piece of bone that we've got sitting over there. So whether you're a believer in design or evolution, it doesn't make a difference to me. It's just a wonderful piece of design, let's put it that way, you know, or wonderful piece of evolution that, you know, we've got these amazing small pieces of bone that work so well with known physics to actually keep us standing upright, you know. So I was in the unfortunate position when I was a student, I think I was in my third year, of playing soccer with some of my seniors, some fifth year and final year students. And one of the guys that we were playing with, and he's a surgeon now, actually dislocated his patella on the field. And with all of us being med students, we all rushed in. And then we realized we had a combined maybe 20 years of medical knowledge between us, but we had no idea of what to do. None of us had really seen patients at that time. None of us were used to examining and emergency work and things like that. And I mean, I was only in my third year, and we still had the old fashioned thing where you did chemistry, physics, and then you did anatomy, physiology, and then you went on to pathology, and then you in your fourth year. And even those who were in fourth and fifth year, those who hadn't done orthopedics or the knee, you know, they just didn't have any idea of what to do. So one of our professors lived directly across the soccer field where we were, and we went to him, and he just looked at us blankly and he said, "I'm a microbiologist. Why are you all asking me?" And it was one of the funniest things I've ever seen. Just the look on his face when we all came running up to him. I suppose we were all panicked at the time. In any case, he told us, splint the knee, take him to the hospital, they'll do the reduction. And that's exactly what happened. And poor guy ended up having one of these congenitally lengthened, you know, it was a congenital defect. He had a long patellar tendon, and he did dislocate it again a year or so later, and then he went in for a procedure to have it sorted out. So here we're going to talk about a few patellar fractures. So here we see a transverse patellar fracture. That's what we've got here. So it's not an easy one to see. That's the most important part, you know. So if you were to just take an X-ray and have a look, you'd have to judge it based on the patient's symptomology. So the patient's symptomology would be, of course, pain, swelling, inability to bear weight, and things like that. And if you look here, and if you look very carefully, let's try and draw it out here. Let's get a thin line going over there, maybe in red. So let's just try and follow that. So if we try and follow that, you can see that it goes there. And then we've got a little crack that's going up there. Got a little crack that's coming down here. Got a crack that's going across there, and possibly even two cracks that are running through there. So it's quite an extensive fracture. It may extend more, but I haven't checked my eyesight in a little while. So, you know, I could be missing out on some over there, but, you know, there's definitely a fracture that's going on over there. All right. Sorry, let me try and get to the next slide. So this what we've got now is an avulsion fracture. So with the avulsion fracture, you can actually see the piece of bone that's been dislodged over there. Now, with this piece of bone that's been dislodged, you can see there's an upward movement of the patella. And this normally happens during severe flexion of the knee. So what's happened is that, again, let me just try and get it over here. So you've got your tibia and your fibula who maybe have gone right to the back over there. So you end up with the situation where your, let's say your patellar tendon is normally sitting, let's say somewhere like that. All right. And then during a case of an extreme extreme flexion such as that, it would get pulled maybe like this, and then hyperflexed all the way over there, and then resulting, of course, in an avulsion around that point at which it bends. So you get these types of avulsion fractures that can happen. It can occur sometimes with longitudinal force, but it's not really that common, I must be honest. I've never really seen it like that. So you may see a piece of bone that's split off, and sometimes the avulsion can occur at other places. Of course, you can get an avulsion rather on the tibial tuberosity. It's not very common to get it on the femur, as that's not generally one of the weak points associated with the patellar tendon, but rather as it crosses over the patella and then as it joins up to the tibia as well. So these are the more common areas in which you'd find an avulsion fracture. But again, it's one of those things that you'd go on clinical signs and symptoms. So these patients are in severe pain. They don't come in like a normal soft tissue injury. They are really screaming in pain. It's one of the more potent pain givers, if I can put it that way. I'm not sure if I'm using the right words, but patella injuries for some reason are extremely painful. I think possibly to do with the periosteal covering of the patella and its correlation to the femoral nerve architecture and things like that. But they're exquisitely tender and exquisitely in a lot of pain. And it's the body's own reaction. It does not allow any weight bearing at all once that patella is out of commission. So it's one of those things that you've really got to look at and see what's going on. So if we have a look here, here we can see a comminuted fracture of the patella. So it's quite easy to see. If you have a look there, you can see this patella has been torn to shreds. There's really nothing that's left over there. Now, this is normally with direct force that it would come on and it would hit the and it would affect the patella like that. Yeah. Sorry, just trying to get something up over there. Yeah, my apologies for that. A bit of a pause. It was just something I had to just quickly take care of. Okay, so as you can see, it's quite easy to make out over there. So these normally occur with direct force to the patella. They're often associated with other injuries as well. They can also be associated with severe flexion injuries, even with, unlikely with severe extension, but more common with severe flexion injuries. So you get multiple avulsions, if you can put it that way. But the more common mechanism is direct trauma to the patella itself. And again, not a pretty sight. Very difficult to actually put right from an orthopedic point of view, but one of the things that they do have to sort out. So these are not the type of patients that you would send home or you would just put in a supportive device. These are the types of patients that need to be seen quite urgently by an orthopedic surgeon. So if you are in an area that doesn't have an orthopedic surgeon, you're working in a rural area, these are the types of patients that you try and get off to your referral center as quickly as possible. So here we have a comminuted and sagittal fracture. So here we can see the comminuted fracture from there, and here we see a sagittal fracture. So it's not the same fracture. We're just looking at other fractures now. So I hope you don't think that these are the same. So this is again, a lovely view of the patella, and you can see that sagittal fracture running through there. And here again, you can see another comminuted fracture over there. Here you can see a bit of an avulsion on that side. There might also be just a bit of a tibial plateau fracture over there. So these are often associated with quite significant trauma, quite significant force that's placed onto the lower leg, and that's normally what causes these injuries. And again, clinically, what you find is a patient in severe pain, severe swelling. Very often there's a hemarthrosis associated. There's severe edema of the knee. There can be dislocations and ligament and tendon injuries of the associated structures as well. So it's very rare. It's not very rare, but you've got to have a look at everything. Don't just look at the patella itself. But isolated patella injuries do happen happen, of course. Okay. So what do we find on clinical assessment? As I've been saying, so patients will present with knee pain and a knee fusion. Patients will also must have the extensor mechanism evaluated. So this is one of the things that I was talking about. So as I was saying, it's very difficult for us to actually extend our tibia and fibula without the patella. And disruption of the mechanism means that your patient's going to be unable to bear weight and extend if it's not fixed, operatively. So what you've got to see is, can this patient extend their leg? Now, in most cases, it's a difficult thing to do in the acute setting of an emergency department because the patient is in a lot of pain. They're holding their leg in a fixed position. They're guarding it. So it's really one of those things that you've got to note if it isn't there, but you can't say, all right, listen, because it isn't there, this patient definitely needs a procedure or needs a fixation or needs to go into theater. But it's one of those things that if you note that it is completely absent, you have to put it there, Now, if the patient is able to extend their knee from a flex position, that's great. That tells you that even though there is an injury, the chances of the patient needing a procedure are dramatically decreased. And if the patient is unable to do that or unable to extend the lower leg against gravity, then it indicates that there's an extensor mechanism disruption. So once those things are present, then an orthopedic surgeon has to be involved. Now, my honest opinion, working in the emergency department, patella injuries are not that common. It's not something you see every day. You might see once a month or twice a month. Even in a busy emergency department, you may not see them for months on end. So when it does come through, I always get the orthopedic surgeons involved. If the orthopedics are not available for whatever reason, then make sure the patient is supported. Even if it's a dislocation, even if it's a minor fracture, even if the patient is still able to extend, the reason being there may be something that you are missing. And an orthopedic surgeon is trained on the knee to a much greater extent than an emergency doctor is. Our job, remember, at the end of the day, is to look for danger. And if we suspect danger, we don't take the risk upon ourselves and say, well, we are discharging the patient or we are definitely key. It's always better to get a second opinion. It's always better for the specialist in the area to say, listen, everything's okay. I agree with your treatment. Send the patient home. This is not just for medical legal reasons that I tell you this. It's simply for the sake of the patient as well. The last thing you want to do is send a patient away and they develop complications, and later on that patient's entire life is ruined simply because you didn't pick up a phone or didn't arrange for a follow-up. So as I say, with the extensor mechanism, because it's such an acute setting that we work in, very often the patient needs time for swelling to go down, for them to have a bit of analgesia, for them to have a bit of support, and then you'll probably be able to test them probably after 24 hours. If you're lucky enough to have a good short stay ward, which unfortunately in our hospital we don't, but if you work in a hospital that has a good short stay ward, that has the ability to keep patients for a more extended period of time, keep them there, test them after a little while, see what's going on. If you work in a hospital where the emergency department is in charge of all immobilization of joints, then I would say don't put the patient in, for example, a full cast or anything like that, but merely a supportive cast, recheck them, see what's going on, and then try and get the patient assessed by an orthopedic as far as that. All right. So what are other indications for surgical intervention? Displacement of fractured fragments more than 2 to 3 millimeters, or an articular surface incongruity greater than 2 to 3 millimeters. Basically, a comminuted fracture, anything that shows any sort of displacement or, where the fragments have moved away from one another. It's very often very difficult for us to tell exactly how far it is. So these are the cases where, you've got to get your orthopedic surgeon involved. So what I'm saying at the end of the day is get your orthopedic surgeon involved, even if it's not in the acute phase. You're not asking them to get out of bed at 2 a.m. or leave theater and rush down, but at least they should have a look at the patient within 24 hours to see what they would prefer to do. Okay, so this is a bipartite patella. All right, and a bipartite patella is a congenital deformity. It's something that a patient is born with. Now, this mustn't confuse you, and this mustn't make you worried. So one thing that you'll notice about this is that the edges are actually quite smooth. They're quite rounded. It's not a fresh edge, if I can put it that way. And it's quite a common finding, here we have a bipartite and multipartite bipartite patella. So these patients are very often present. The only time you'll find it is if the patient has an injury to their knee, and then coincidentally you do an x-ray and then you find it. Now, if you were to call this a fracture and get the patient to an orthopedic surgeon, then nobody's going to fight with you. They're just going to tell you at the end of the day, well, listen, you made a mistake. This is actually a bipartite or multipartite patella, and it's a normal variant. There's nothing that you really need to worry about, and it's not a fracture. But the main thing to notice, and even if you are asking for a consultation, is to be able to tell the orthopedic surgeon that, listen, it could just be bipartite. We've got a patient with nice, smooth, edges to what would be the fracture line, but I'd like you to have a look at it as well. And this is one of those cases where, despite what looks like a severe fracture, you've actually got a patient who can extend their knee, is able to bear weight, is able to do all of those things. So it's not as though you're going to find these every day, but when you do find them, at least you know what it's called. Okay, so generally the finding is asymptomatic and it's considered a normal variant. So it's important not to mistake for patellar fracture, but it can happen, especially if you're early on in your career. Nobody's going to get cross with you. Nobody's going to get angry with you unless you get them out of bed at 3 a.m, and tell them they've got to rush down because they've got to get the patient into theater and things like that. So it results from incomplete fusion of one or more of the patellar ossification centers. So as I say, you said round, smooth, and sclerotic edges, sorry, I forgot to mention that, characterize these normal variants. And conversely, acute fractures have jagged edges and naked trabeculae and can mentally be reduced to a perfect patellar shape. And mimickers may be bilateral. All right, so let's have a look and compare two. So let's go to a fracture. All right, so here you can see these jagged edges. Now they talk about naked trabeculae. You can't see naked trabeculae over here, but where they were talking about you can mentally reduce this into a perfect shape, you can see you can get this back into the shape of a patella. And if you look at this bipartite, you'll notice that you somehow just can't get that edge back in, and it's quite round. And as you see, it is a bit sclerotic compared to the other one. Here you can see the sclerosis of the edge a bit better. And again, you can see that you can't perfectly reduce all of these back into the patella to make a perfect patella again. So those clinical features, I hope, make it a bit easier for you to pick out the two that you could get. So this is a patella alta or a high riding patella. So once this happens, then it indicates a tear of the patella ligament, the patella tendon. And it's one of those things where a patient, again, will present with the inability to bear weight. They'll have the inability to extend the leg. They don't have a fracture of the patella itself, but it very often requires CT scans and orthopedic intervention because you've got to get this back down. You can't leave the patella lying up there. It very often needs the patient to go to theater and things like that. It's not a medical emergency. None of these are medical emergencies per se. But they do need to be seen by an orthopedic specialist, that is for sure. The other things that I've often found with these patients that they do sometimes get severe injuries to the bursae that are surrounding. They do often have injuries to the collateral ligaments. They can have injuries to the anterior cruciate ligament, especially if it's direct force onto the patella, simply because the tibia and the fibula sometimes get knocked, or the tibia specifically gets knocked backwards. You do get tibial plateau fractures associated with patella injuries. So don't just look at the patella in isolation and say, okay, listen, everything's okay. I'm perfectly happy with it. No, sometimes you really do have severe problems associated with all of these. And they can be difficult in the acute setting. If there's a hemarthrosis, if there's a lot of other things going on, it can be very difficult to, in the acute setting, to say how severe it is. So it's always better to have a second opinion and to get an orthopedic surgeon on your side. But you've got to be clinically aware of what you're finding. You've got to be able to speak the orthopedic language. You've got to tell them, listen, we've got an acute injury. I'm unable to do all of the motion tests. However, the patient is unable to bear weight, severe swelling, severe pain. Patient is unable to extend currently. On X-ray, that's what I can find clinically. Maybe I've drained some blood from the area. I've noticed the bursa is inflamed. I've also clinically palpated the split in the bone, and I can see it on X-ray. And you need to have a look at this patient as well. So that's how I would suggest that you move ahead with that. This is a nice one, and I know one doctor who will see this and who will immediately recognize it, who's also on the group. He recently had a patient like this, and he's in partnership with a much older doctor who actually taught him about this. So, he'll be happy to see this as well. So Osgood-Schlatter disease is commonly seen in young, healthy, let's say preteens and teens who are athletically active and who suddenly present with severe pain along the tibial tuberosity. All right. So it's anterior knee pain in the skeletally immature athletic population. So preteens and teens. All right. So it's atraumatic and it's an insidious onset. So it's not an acute onset. The tenderness at the patellar tendon insertion point, which is more or less just next to the tibial tuberosity. All right. It's self-limited and occurs secondary to repetitive extensor mechanism stress activities such as jumping and sprinting. So it's quite a common injury, and it's something that you'll see whether you're working in emergency medicine, family medicine, you will see this type of an injury. Okay. So the pain level is actually what dictates the treatment. So you may have just ice, NSAIDs, just a bit of stabilization, activity modification, rest, things like that. And for some patients where it is quite severe, you can get your physiotherapist, your biokineticist involved, because they are prone to getting it again or getting it on a regular basis. It is a purely clinical diagnosis. This, what we see here, is quite an odd finding of a bit of lifting there of the epiphysis, and it's not a common finding that you'll see. So the main thing is that we do it just to rule out other conditions that may be there. And like I say, you may see fragmentation of the tibial tuberosity, which is what we are seeing over there, but it's not common. Most of the time you do see just a bit of swelling and pain. Okay, so that's just a little overview of patella injuries. And when I looked at this, I couldn't believe, but it's true. Her knee really does look like Kanye West. I don't know why that is, but we all come in different shapes and sizes, and we all have our odd things that we have on our bodies as well. This was just quite amazing that it actually looks like Kanye West, and I hope she's making a lot of money off her knee as well on the social media sites, because definitely that's something you can monetize. But anyway, I hope you guys enjoyed that, and I hope you learned something from it as well. And in our orthopedic protocols, we've got all of these injuries as well, and I hope you guys will at least be on the lookout for them. And I know it's not a commonly seen injury, so it's one of those things where sometimes as a junior or an inexperienced doctor, you may not necessarily see it that often. So if we don't, as they say, out of sight, out of mind, and it's one of those things that maybe you don't really keep an eye out for. So keep an eye out for the patella. It can get injured. It can be serious, and make sure you look for it. Okay, thanks everyone. Keep well, and hopefully we'll have another one tomorrow. Bye.